All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So I hope that you are doing great. Once again, I hope Rima, Margaret, Roman are doing well. Um, Luis Grande, I saw your question. I forgot. Sorry about that. But you had a very interesting question. Um, and John Snyder says the problem is N and E proteins cause severe lung injury. So there has to be some thinking to be done. In general, I would say that vaccines and billions of doses have helped a lot. A lesser number of people are left, or maybe still more, but considering youngsters. Secondly, Omicron seems to be becoming milder, at least for the vaccinated. I am still collecting data for unvaccinated. Uh, I am seeing some doctors saying for unvaccinated it is as um, acute as it was as Delta was. So I have to collect some data there. My point is maybe this would all work out. We'll see, at least so far. Um, so Doug's question was, how often is this happening? Doug, actually, there is no data to back it up other than those tests that I showed you, where there were some long haulers, and then there were some folks who had lingering symptoms after the vaccine, and some of them had tinnitus, and they did these panels, and then some of them came positive for anti-ACE2 antibodies. I was speaking with them, with the person who shared that with me, and he said the data is not large enough to be able to say this is significant or not. Alexander says, I have long COVID and the mechanism explained looks exactly like what I have, Moderna vaccine 2 times. Sorry to hear that, and I hope you're getting help. There is one more thing to think about. At the end of the day, with majority of the pathologies, the outcome is inflammation. And when we do not know the underlying pathology, one can at least control the inflammation by steroids, but steroids cannot be given in larger doses and for longer times. So these are good stop gaps in the meantime. So I think the panel to understand what is going on and then uh, correct medication is important. In the meantime, anti-inflammatory can help. So I think that is how doctors will have to figure out some protocols to work with. So Donna says, do these binding issues apply to the Novavax? So they would apply to every vaccine that has the spike in it. Now, at the same time, please realize that this is number one, a theory, a hypothesis. It is very plausible. Number two, if it is occurring, it will happen in some. That doesn't make it all right or better, but that would happen in some because not everyone would have exact matches for receptor binding domains. Now, how many, we don't know. Um, Doug says video quality is poor. I'm so sorry about that. Let me see if my network, the correct network is connected. So apologies. Bambi says, hope you had a good Christmas. Absolutely. Thank you very much. Missed the first live. Didn't think you'd be in a stream on bank holiday Monday. My aunt had a major CV on Christmas Eve. She's 91, can't speak. Oh, I'm so sorry. Um, so I hope that she's getting help, and it's major CVA. My apologies, and my sorry for this as well. So I wanted to actually, there was a discussion internally today. My wife wanted to go out, and so she said, maybe you can skip this. It is, nobody's going to mind it because it is part of the holidays. And I said I want to discuss this topic. So I hope it was useful. So Aliji says Pfizer booster safe for a woman suffering from right bundle branch block. So Aliji, I cannot give a specific advice, of course, right? I hope you know that. From a booster point of view, if the first two doses, I'm assuming from a booster that there are two doses that are already given and there is no issue, then ideally, in theory, there should not be any further issues either. Sharon says chronic fatigue syndrome likely to be from the same mechanism as proposed with long COVID. It is one of the possibilities, and so possible. So now, how many mechanisms do we have for the long COVID? So I'm going to put this question out here so I don't forget it. Louis, 1 second. And I'm going to very quickly um, so we now for long COVID, the mechanisms so far that I know, and there may be more. One is, remember we talked about blood cell morphology. So there was a study that showed that RBC and other blood cells, their structures changed. Good news there was that the RBCs are replaced over time and so on. So it would go away in a few months. But that was one pathology. Then Dr. Bruce Patterson, all their research that S1 part of the spike protein is sitting in the monocytes, and then those monocytes are continuing for the inflammation, especially at the boundaries of the blood vessels, causing inflammation, for example, at the blood brain barrier or other areas of blood vessel barriers, and they are causing issues. So that is second. Then third was this mechanism that we just saw, where this is called network hypothesis. Network hypothesis, where there is an anti-idiotype antibody. And now it is possible that anti-idiotype antibody is formed in everyone. Normally it is formed to clean out the remaining antibodies that body produced. So these are like a mop-up system. And they can cause this issue as well. Not in everyone though, as I discussed before. So this is another possible hypothesis. Then we know that macrophage activation syndrome can be another. Then we know that mast cell activation syndrome or unmasking is another. And then if you think about Dr. Stephen Phillips's discussion, he feels that there is a possibility that there is an unmasking of the chronic vector-borne diseases, and for example with the Lyme and Botnella, etc. So these are the kind of pathologies. Of course, we're not talking about sequelae, meaning the damage done by COVID and these effects that continue on. We are talking more of a after COVID is over and there are still side effects. Okay, so now Luis Grande. Same question as John. Also, how do anti-idiotype antibodies that have the same shape affinity to ACE2 cause similar reaction as it is not the actual pike? Very good question. So I do not know the John's question, but let me do this one and then I'll go back. So here is, let's say, a cell. A cell. This is a cell. Okay. So here is a cell. This cell has, we know that it has ACE2. Some cells have ACE1, correct? So one of the function of ACE2 is to take the molecule angiotensin 2, Ang2, and convert it to Ang1 to 7 heptamer, correct? Kind of neutralizing it, but there is function of this as well. And then we know that that would go and work on MAS receptor. And I have done this discussion 1.5 years ago. The basic idea over here is, number one, make eyes. I have been declared unfit to teach doctors by some auditors because I make eyes. Okay, so so I'll make more eyes. So at least on this, this is a chit chat. So ACE2 is present here, and so one problem that will occur is that when antibody is occupying the ACE2 receptor, it is going to stop the ACE2 from doing its normal function. And so that is one effect. That is a very similar effect as when the virus binds to ACE2. And what happens is when a receptor is bound, there are lots of behaviors. And Lewis, you are a medical student, you know them. Sometimes things attach with the receptor and then detach from it. Sometimes they stay attached, and then the whole complex, the ligand and the receptor, they both are internalized in the cell and recycled. In the case of the spike protein and ACE2, that complex is recycled. It is internalized, downregulated, and then recycled. I believe it would happen the same way over here. So that reduces the number of ACE2s to do their function, although more ACE2s will be produced in a few hours and will be brought up. So this is one action. The second problem that this would do, which spike alone can do as well, is that when the ACE2 is connected with, then it has the conformational change. That change internally causes the second messenger systems that are connected to ACE2, which in turn cause a cell to start producing inflammatory cytokines. So cell becomes disturbed with the signaling mechanism, and it would start producing inflammatory cytokines, which in turn would start creating inflammation. So that is two. A third mechanism for the problem, which spike cannot really do, is the following. When the antibody is attached here, antibody, Lewis, you know that antibody's constant region is the biologically active part, correct? So what will happen is a macrophage would run along and it would connect with the constant part, right? So let's say this is a macrophage, right? This cell would be called opsonized now because the antibody is attached to it. So this is opsonized, and the macrophage would come in, and that macrophage would love to eat the cell. Of course, in this diagram, macrophage is smaller than the cell, but the macrophage is going to be bigger. So it is going to pick up the whole thing and destroy it. So that would happen. Then, so let's say 3. Then wherever the antibody is connected, when it becomes connected, complement becomes activated, correct? The activated complement in turn will cause local surface damage, whichever surface it is on. So I hope you know, I'm sure you know, that the complement cascade would become triggered, and then there is this complement pore complex that would be formed that would cause the cell to become destroyed by leaking the fluids. So that would happen. So ACE2 receptor downregulation would happen, ACE2 receptors unavailability would happen, ACE2 receptors triggering, causing secondary messenger system inside the cell will happen, which is known in a study to be toxic. And then the antibody binding would cause opsonization. Antibody binding will cause complement activation, which in turn would cause opsonization as well. So this cell is in serious trouble once this happens. So I should not make a smiley face. He's like, what is going on? So now, if I go up, what was John's question? Gold Country says, please teach us about hemorrhagic fever and what the outbreak in China means to us, because the virus will the prophylaxis work for C19 and a hemorrhagic virus. Hopefully, but Gold Country, I haven't read about that. I haven't read which virus is doing it. Is it dengue or something else? I have to read up. I'm gonna scroll upwards to see if there is John's question there. Lad Lodazal says, if someone's immune system made anti-idiotype antibodies after an early infection, could an Omicron or other reinfection ramp these up again? The so in theory, when the exposure or vaccine will be given, or that antigen is exposed again, that person would create antibodies that would be against the anti-idiotype antibodies. So they would wipe them out for a few. And so the person would actually feel better. The question is how long, and would they start becoming formed again or not? That's a question. Don't know the answer. So far, there have been some people who have said that after their long COVID or lingering side effects, they with vaccine they felt better. Some, not all. And now this makes sense why some will feel better and not others, because not everybody is going to have the same exact epitope structure. So Richard Cooper says, I've received both Moderna vaccine along with the Moderna booster. Do you think if I were to catch COVID, it would be mild despite being obese and having psoriasis? So the uh, see, it puts me in a spot because I cannot talk about a person, and I should not talk about it. It's not that anybody is binding my hands, but I should not, because there is no doctor-patient relationship. So I can't talk about a person. The generality is that when the Moderna vaccine is given, Moderna booster is given, normally it depends upon when were these. If these were recent and the antibody system is ramped up, immune system is ramped up, then that person is protected, and obesity or other comorbidities are actually the indicator for vaccines to protect the individuals. So ideally, in theory, vaccines provide that protection. And then the uh, psoriasis. So if somebody is taking some immunosuppressants, then that is a different discussion to have, and that would be with your doctor to say how immunosuppressed I am. Michael Steyer says, do you think that the vaccine injury will continue to produce the anti-idiotype antibodies? So if I apply this theory to some of the patients that I know, including my own family members, they keep going for months. It becomes lesser and lesser, but this continues for months, and it can flare up with any other thing that causes inflammatory triggers. So it is possible that they are making this for a longer period of time. I think the best way to handle this is to get the ACE2 anti-ACE2 antibody panel. And that was, what was that company's name? Again, I have no relationship at all. I don't even know them. I have no financial interest with them. My wish will be to invite them so they can speak with the cool beans here. That would be a total interest. And so I think that that panel will be very interesting. I think that panel is really important. Anti-ACE2 antibodies. So John Titer says, should individuals get monoclonal antibodies for Omicron? Is there any downside? Yeah, the only downside. So let's say that monoclonal antibodies are working. If they're not working against Omicron, then we have a different kind of a problem. But let's say these are working. The only thing, if you, for example, I believe Regeneron says it on their medicine, they say that it is possible that the future attacks may not be as well handled, which some people become upset and say, does this mean that taking Regeneron today will make my future COVID exposure worse? That's not what they're saying. What they're saying is, in the body, so let's say this is a person's body, and the person had the virus. Virus came in, we quickly injected monoclonal antibodies. Really, a cocktail, correct, in case of Lilly and Regeneron. We injected them and they went and they mopped up the virus very quickly. If they mopped up the virus very quickly, that gave a smaller chance to our body to become trained. So now, if this person now says, yay, I'm good, I had the infection, I survived it, and now in the future I'm good. And Regeneron folks are saying, hey, because we had mopped up the virus quickly, your body may not have learned and not have created enough memory cells to be able to attack them in the future, attack the virus in the future. This is just as if to say just take one vaccine dose versus two doses. So that is the amount is less. So that is what they say. And so this is the person now. Okay, so that's what they say. So going back to the question, individuals get monoclonal. Monoclonals are really important to make sure that one doesn't become worse. So you must have seen when Trump had the infection, within 2 days he was feeling better, monoclonals. When what was his lawyer who had that little thing seeping from his head? Giuliani. When Giuliani had it, monoclonal. You would see a majority of the people. I saw a patient's comment who they sent or wrote somewhere yesterday, and they said they became sick, got monoclonal, 2 days later, fine. So monoclonals have this potency to help. And I also read, I think it was Dr. Kori who had, no, it was, I believe it was Dr. Fareed Jalali who had retweeted another patient's story where they said, we ended up in hospital with COVID. We requested them for monoclonals and they refused. I cannot imagine why a hospital, they could refuse to say the patient is not in the viral phase, but how can they tell exactly they are in the viral phase or not? So strange way of practicing medicine nowadays. So as son, thank you very much. Andre says, could you please explain us the concerning results of Novavax safety study in US and Mexico? Thank you. So I'll have to write it down. 1 second. Novavax. Okay, got it. So Stratolite says, just jumped on. Welcome. Does Novavax have same hypothetical risk? Yes, because it is also, if their receptor binding domain is different, then that is different, but I don't think it is different. I used different word 3 times in a sentence. So in theory, yes. Uh, Iron Bubble says, are there any studies on COVID producing viral conjunctivitis in both eyes? So we know that COVID earlier variants were able to create red eyes and burning eyes and conjunctivitis. I have heard less in the latest variants, but it has been a property or a feature of this one, these viruses. And yes, you can look up the studies as well. Many of those came in from China in the beginning because infection started from there. Lisa says, my daughter in Finland said they're about to release a nasal spray COVID non-mRNA vaccine. Very interesting. Do you know about that? No, but it would be very interesting to see. Of course, in the nasal area, one can be so creative with the kind of antigens to throw in. So if J&J is really too short vaccine, which they don't say, it's me who says it, that they should have been too short vaccine. Is the second shot the lower dose booster, if not boosting with J&J again, or one job of the full dose, one jab of the full dose? So is the second shot the lower dose booster, if not boosting with J&J again? So I think the um, Pfizer is the same dose in booster. Moderna is half dose in booster. I do not know about J&J, but you must have heard that US prefers Moderna or Pfizer over J&J. So what I do not know is J&J's own booster. I think it is a full dose booster. So Jasmine says data from Denmark and Canada showed that partially vaccinated people are significantly less likely to catch COVID, be hospitalized than fully vaccinated people. Do you know why this might be? Because the partially vaccinated, couple of reasons. One, the dose is smaller. Secondly, they do not have enough time yet for their immune system to fully ramp up. So even when it will fully ramp up, it won't have enough power in it because enough number of cells are not produced and enough memory cells are not produced. So it is going to give a weaker response. Vaccines are not like virus, which continues to increase until the body catches it. So if the body does not catch it, it would increase more. So imagine the dose increasing. If body still does not catch it, it would increase more. So until the body says, you know what, enough, I'm going to start wiping you out, and then the body would have to learn to beat it and then beat it. In case of coronaviruses, it's just that SARS-CoV-2, they can kill us while body is trying to figure it out. They can actually partner with the immune system to kill us. So M. Gregory says CDC cut down quarantine from 10 to 5 days. How did they come up with that? I think that, so now this is a political part. And I am not very savvy on politics because I just don't read it. But I read somewhere that they said because we need healthcare workers, because of that, they can just quarantine for 5 days. This is a very similar behavior as with the mask in the beginning of the pandemic when they said mask is not needed. And then they came back afterwards to say, we said masks are not needed because healthcare workers needed them. Now, healthcare workers, I believe they have been letting them go because of the workers saying vaccination or no vaccination. And now the remaining folks are there who are having to bear the brunt of it. And now to say that the quarantine should have been 10 days, but well, you're okay after 5 days, it just, I responded to that tweet and I said, science has spoken. I was being sarcastic. I these decision makings are just beyond me. Lorna says, is there any other way to prevent these antibodies from being formed, anti-idiotype antibodies from being formed, other than ensuring there is no exposure to COVID? Also, great sweater. You look hip. Thank you very much. I should actually wear this as well. So look, Finbean, I keep your this thing over here. Now I am a complete hip. Okay, so thank you very much for the sweater. So my wife took pity on me to say, you keep wearing that one sweater again and again. I should buy you some more. So she bought me some more. Okay, so prevent these antibodies from being formed, other than ensuring there is no exposure. We cannot really do that. It is going to be very difficult to say one kind of antibody should not be formed. It's almost impossible. So Janet says, hip, thank you. Uh, Colombian Bean says, previous question, part vax, less likely to be hospitalized than fully vaxxed. Less likely to be hospitalized than fully vaxxed? I would have to look at the data. I saw some data over the weekend where people were saying, well, here is a report from UK that showed that fully vaxxed are more likely to have Omicron. And they converted that message into fully vaccinated versus unvaccinated. While in actuality, they were saying that, so I became interested to look it up. I had thought I will not do anything this weekend. Anyways, I think what they were saying was, if you have, forget about unvaccinated and vaccinated, if you have vaccinated folks and if they have become infected, then if you test them for what kind of virus they have a greater chance of having Omicron than others. Which I would say in general nowadays it is becoming true that if you take any group, vax, not vax, any group, and in majority of the countries, if you see what sequences infecting them, it's going to be Omicron. But I have to look at this data to be able to answer this. Secret Owl says, Dr. Bean, will a necklace made of garlic work against COVID? I wish it did. Otherwise, we will all be running around with garlics. So, Poke Pact says, I am vax injured and suffering. If I'm one of the rare cases, am I doomed without treatment? I'm getting to no help in my area. So, one, my own wife has some symptoms that are still continuing. And I am hoping that steroids are the kind of things that are available everywhere. So talk with your doctor and see at least if you can get some steroids, and that would help. I know steroids long term therapy is not great. My mother had an autoimmune disease and she took medicines, steroids from 29 years of age till 65 when she passed away. And it was not the best thing to do, but at that time we didn't have other therapies. So steroid for term are actually fine, and I hope that you can get to them. Then also look at FLCCC and see the recover protocol over there. Also look at Dr. Bruce Patterson's protocol. Really, the only thing with the I recover protocol is low dose naltrexone, which is part of I recover protocol, and then maybe sometimes Miraviroc. I have never used Miraviroc, so I have no idea. But that's the only difference. Otherwise, really, the protocol, I'm happy to see that I started this discussion last year in May, June timeframe about steroids being very useful. And that is the mainstay even till today. And again, it is also not necessary that a long haul is because of this particular issue. So Golden Time says, can this spike protein caused anti-idiotype antibodies occur in inactivated vaccine like Covaxin? So that's a very good question. Inactivated vaccine also has spikes in them. And so it is possible that we would still make those. My hope is that because there is a lot of other antigens from the virus, maybe the amount is lesser, but in theory, from a mechanism point of view, it could happen there as well. Okay, so Stratilize says clarification, the new 5 days should be clear that they said if they are asymptomatic. Ideally, so asymptomatic is still not the best thing to do. Ideally, it should be with the negative test. So they should say if somebody is asymptomatic and has tested negative twice, then they can come back. A cook says, can you get COVID twice? Dr. McCullough says you can't. So So this is how it happens that I cannot answer fairly, because then people make it a personality fight to say, well, I like him more and you suck, and so I don't. uh, yes, you can get infected twice, you can get infected many times. My niece got infected last year, then got infected again, then got vaccine. She's a healthy young woman, very, very energetic, very active, and she has the infection again. So infection is I have said it many times. This is a respiratory system. Vaccine or previous exposure does not guarantee that the virus will not end up in our mouth or nose or eyes again. Number one. Number two, it really depends what is the state of our immune system and the state of the virus and the load to be able to tell if we would actually develop symptoms or not. So, sleepy fish, good name. Do you think some PCR thresholds are set too high and thus maybe creating too many false positive? Maybe at the end of the day, I usually do not look at the cases. I usually look at hospital admissions or the sad part, the deaths. I don't look at the cases as a great indicator. It is interesting to see, for example, South Africa going up. So yeah, that is an interesting thing to observe, that how a new variant pushed it up. But again, cases, number of cases can change for so many dynamics, including CT, including number of tests, including willingness to test, and so on. So hospitalizations are important. Jim says, I forgot about LDN. I have some in the refrigerator. Good. Have you seen additional myocarditis? JM says, have you seen additional myocarditis data in kids and men less than 40? Not yet. I haven't been able to read it. I will. D is also saying can and have gotten. Yes. So, strategic services, to your answer, cure no, but support yes. To your question, I'm deliberately not showing the question here. So Sheena says, why does Israel want to do a fourth booster? So I think they have a selection criteria to say these are the kind of folks who might need the fourth booster. I have to look it up. I can understand. So let's say if someone is immunocompromised and they are just not able to create enough antibodies or enough memory, or they're taking actively immunosuppressants, or they have cancers, or they have bone marrow issues, or they have organ transplants, or they have HIV. So, in such cases, to keep them protected, they may need to just keep the immune system artificially ramped up. I actually think nowadays the AstraZeneca type long term antibodies are also a great solution. I think they do not need every 6 weeks a new booster. They may continue to go on for 6 to 8 months. Plus, all these pills may be useful as well that have been authorized nowadays. Sleepy Fish says, thank you for your work. Thank you very much. You're very welcome. Dan Ban fan says, if we lose the thymus gland as we age, how can elderly still produce T cells for COVID? So that's a very good question. In immunology, we still think about it. We still produce a T cell because T cells are not made in thymus, they're trained in thymus. They are made in bone marrow, just like B cells. It is that they train in thymus. And the newer T cells that are formed, how are they still getting trained? Are they getting trained in thymus still or some other place? That is one interesting mystery. But they're made in bone marrow. Out of 10 friends who had the vaccine, all got infected after the vaccine a second time. I wonder why is that. I have another friend who are unvaccinated and only got it once. I wonder why is that. No idea until we look at their behavior, their vitamin D levels, their immune system's behavior, and so on. There are so many factors. Lodazel says, have you come across the Shertow Steineol SARS-CoV-2 persistence? Let's look at it right now. That is an intriguing mechanism because I used to think in the beginning that there is a um, SARS-CoV-2 persistence, but so let's see. Is this the one? Interesting. So COVID-19 is known to cause multi-organ dysfunction in acute infection with prolonged symptoms experienced by some patients, termed post-acute sequelae of SARS-CoV-2. However, the burden of infection outside the respiratory tract and time to viral clearance is not well characterized, particularly in the brain. We performed complete autopsies in 44 patients with COVID 19 to map and quantify SARS CoV 2 distribution, replication, and cell type specificity across the human body, including brain, from acute infections through over 7 months following symptom onset. We show that SARS CoV 2 is widely distributed even among patients who died with symptomatic to mild COVID 19, and that virus replication is present in multiple extrapulmonary tissue early in infection. Further, we detected SARS-CoV-2 RNA in multiple anatomic sites, including regions throughout the brain for up to 230 days following symptom onset, despite extensive distribution of the body. We observed a positive inflammation or direct viral cytopathology outside of the lungs. Our data prove that SARS-CoV-2 causes systemic infection and can persist in the body for months. This is an interesting one because I've done this discussion sometimes before as well. Somebody who died, it is not necessary that they had to become severe to die. Even if they died with milder, but they died. When they died, their system would start breaking down. And one of the part that is going to break down are the barriers and the blood vessels. These are the kind of reasons eventually that cause heart failures and lung failures and brain failures, and the person dies heart failures. So it will be very, I have this curiosity, so I'm not dismissing them. I have a curiosity that a person who may be SARS-CoV-2 positive, if their CSF is tested for SARS-CoV-2, the only case that I know was my friend's son who unfortunately passed away from SARS-CoV-2. They thought it was meningitis as well, or meningitis. So they had done some CSF samples before he died. And so their CSF samples did not show SARS-CoV-2. So that is the only one case I know. So this would be interesting to actually see data in living people versus somebody who has passed away. Janet says, should someone who took the Johnson & Johnson take Moderna or Pfizer as a booster? So they say that Moderna or Pfizer is preferable over Johnson & Johnson. That is a position of the US administrations. So Gino DC says, how do steroids help with long haul? Anti-inflammatory? Yes. Any other things that might help us as well to mop up the spike like antibodies? Not only anti-inflammatory, because it brings down the inflammatory system's function, including innate arms activity with the acquired arms activity as well. So the production of antibodies will reduce as well. Hopefully that would allow enough time for these cells to die away. Eventually these normally die away, and so not only it would help figure out, it would help with the acute inflammation, but also relax the system enough and give it time to uh, for the cells to go away. Hope not enough memory cells will be formed that would then go and become permanent. Now, any other things that might help as well to mop up the spike like antibodies? The only thing that is interesting is, could there be passive or monoclonal antibodies which are against spike? And if they are, they might actually bind to these antibodies as well and wipe them out. That is just my conjecture. D. Mercado says, thanks again, Dr. Me, for all your boldly do to help the world. What advice might you have for autoimmune sufferers regarding vaccine, vaccines, and risk of bad outcome if infected? Many blessings to you. So, thank you very much. Blessings to you as well. Um, for the uh, comorbidity of autoimmunity as well, vaccines are actually asked to take. My thinking is, I did a video talk where I presented a case. I really feel fascinated by that case. And interestingly, not many people watch that video. There is a video in which I presented a paper. And if you don't want to watch the video, in the links, you can see in the description, you can see the link to the paper. They were immunologists who had two healthcare workers who had severe allergic reaction to the vaccine because they had autoimmune diseases or allergic reactions in the past as well. And they gave them graded dose vaccine. So they diluted the vaccine and then they gave them over 2 hours. After the first dose causing severe allergic reaction, anaphylactic reaction, second dose didn't do much. So, of course, the autoimmune disease is different from anaphylactic reaction, but anaphylactic reaction is an overwhelming immune response. So, if somebody has autoimmune disease, they may be able to talk with their immunologist and figure out how to take the dose. Autoimmune disease has a different problem that people may be taking medicines to suppress the immune system. So, if that is only brought down enough that it works fine and it's not suppressed, then they're fine. If they have suppressed it, then the vaccine may not generate enough. So, this is the discussion to have with the doctor. Kelly says, time for bed so I can keep up my immune system. Thanks and love to Dr. Beanie Coolwins. Thanks to you as well. It is 7:41. I should let everyone rest. Um, So this is a very good question. Queen City Dom says, could IVIG help vaccine-induced long haulers? So the the person I'm talking about, they actually tried IVIG, and they said strangely it became a little flared up. So I think it really depends. It is possible that it flared up because IVIG actually went and bound with the other antibodies and the inflammatory response occurred. So that may be actually a sign that this happened. So I think it is worth a try. Crocodile says, is it true? Crocodile keyboards. Is it true that ivermectin arm of the ongoing principal trial has been stopped because Merck are refusing to supply the drug? Yes, they said it is paused because of supply issues. Weird. So, folks were talking about quercetin, zinc, vitamin D's, C's. My whole 1 year was spent talking about these. I have multiple videos that talk about these. So if you would like, please see them. I have a couple of videos which I thought were really interesting. One was a full list of what could occur before, during, after, and what medicines might be useful. And then I did an immune plate, a food plate for a stronger immune system, where I talked about what vitamins may be needed, and if somebody is not taking vitamin by mouth, then what foods, both vegetarian and non-vegetarian, might be able to provide those vitamins. These videos are done many times. Ditching the grind, thank you very much. Holy says, is it possible, in your opinion, to be fully vaccinated, then get Delta and a month later catch Omicron? Yes. So, getting the virus, you can keep getting it every day from the exposure. The symptoms and how severe the symptoms are, that is your immune system's training and its behavior. So, yes, one can. So Thomas says, if we suspect we might have myocarditis, what tests should we ask our doctors to perform? So normally the doctors should be very well versed, but if you think that you have persistent chest pain or myocarditis, then they would do cardiac enzymes. They would do some other tests as well to make sure that it is heart and not, for example, let's say an ulcer or something else in the chest. So they might do chest X-rays, they might do ultrasounds, CTs, echoes, but I think the most important is cardiac markers, EKGs, and they would start from there. So, Jasmine, I will have to look it up separately, um, and read it. So, I have to look at the data to be able to make an opinion. It's not fair, actually, for me to talk about something that I haven't yet looked at. Carlos has a good question. Hi, Dr. Bean. If our immune system creates antibodies against antibodies, so anti-idiotypes, do we also create antibodies? Usually, the original antibodies were against these. So we don't need to create another third type because these two are sufficient against each other. How come that doesn't happen at infinitum? That does, but these two are kind of, this is like you are standing in front of a mirror. These two are sufficient. They are mirror of each other. Thomas Hand, thank you. And with this, Thank you very much, Saraswati. Andrew says, "What is your take on fluvoxamine?" I love it. It's a great medicine. For fluvoxamine, something that I have seen in some people, it really works very well, and it starts working right away. In some people, it exaggerates their situation. So Sean, who we interviewed, he tried fluvoxamine, which exaggerated his symptoms. My wife tried fluvoxamine, and that exaggerated her symptoms. So in some people, it actually increases the issue. When I speak with some doctors, they say that if you hold on and keep going, it becomes better. But I am not experienced with that part. I have never asked anyone to continue if it has increased their symptoms. So Benzo says, so anyone can create those antibodies regardless of the genetics, or do some populations have a higher likelihood? So anti-idiotype antibodies we all produce. That is one way of us to remove the existing antibodies. However, it is the problem is, what is the shape of the anti-idiotype antibody? If the shape of the original antibody against the antigen is complementary to some effective part of the antigen, then anti-idiopathic antibody, would have the shape of that effective part of the antigen and start doing those mechanisms. That is what happens. Okay, so with this, how about we take a break for today? Once again, glad that you're back, happy. Please send your wishes, your prayers. Rima, Margaret, both are feeling better. They're feeling on the better side now. And Roman is still uh, battling with some after COVID. And so please pray for him as well. So, with this, thank you very much. If you would like to support this work, the easiest is like, subscribe, and share. Just like, and that should be good enough. Otherwise, if you wanted to support, there are 3 links in the description. You can buy me a coffee, or you can use PayPal, or you can be a patron. Thank you very much, and I would see you tomorrow.